Today is our multidisciplinary conference. And what we do in multidisciplinary conference, we are going to be unraveling a case, and the lead presenters are from the Faculty of Obstetrics and Gynecology. So without wasting much time, I'm going to be inviting the lead presenter. A brief introduction about the lead presenter. He is a boss when you are talking about O&G. In fact, some people say jokingly that should have become a senior registrar while he was in the medical school. It was so clear that he understands obstetrics and gynecology when you see him talking about obstetrics and gynecology. And he's somebody I'm so proud of. He's somebody that I respect a lot, and he's somebody that most of us look up to as also an elder in the medical field. He's a senior registrar in obstetrics and gynecology, Federal Medical Center, Katsina, in Nigeria. His real name, actually, some people don't know his real name. His name is Sheu Jamiu, but we all call him MJ Black because we have another MJ that is white. So tonight, MJ Black is going to be unraveling the case, and I'll be calling him to share his screen now. MJ, are you there?
Good evening, distinguished colleague. Your presenter for today, Dr. Sheu Jamiu, I'm representing the Faculty of Obstetrics and Gynecology today, the Doctor Assembly, the MD Conference for the month of May 2021. We are representing the O&G department. Thank you. Today's discussion is going to be based on the following outline. We are going to have a case presentation from which we are going to have brainstorm together to talk about the differential diagnosis, and we'll talk about various investigations that have been done for the patient, how it's with the diagnosis, and we'll talk a little about the most likely diagnosis, talk about the incidence, the risk factors. We'll move forward to talk about the pathophysiology, and finally we'll talk about conclusion and references. So today, the case we have is a 35-year-old married Southeastern African woman that lived in New York. She was booked elsewhere. She was a gravida 4 para 1 plus 2, 1 alive. She presented at the decisional age of 36 weeks, 4 days. Her presenting complaint was actually of bleeding per vaginum of 30 minutes duration. She was apparently well until 30 minutes prior to her presentation. She woke up and met herself in the pool of blood. She said to be the blood should be of large volume of bright red color, liquid blood, and there are 3 large clots, each measuring approximately 1.5 centimeter in diameter. The bleeding was through the vaginum. There was bleeding was said to be painless, and there is no bleeding from other body orifices. She reported no recent trauma, fall, or sexual intercourse, no history of headache, no history of dizziness, no palpitation, and she's not a known hypertensive patient. She has had 2 episodes of unprovoked vaginal bleeding at 33 weeks and 33 weeks and 6 days prior to this episode. Ultrasonography examination that was performed during our last prior to that, the placenta was positioned anteriorly along the midline of the uterus, completely overlying the cervical os, and there was no evidence of placenta aperta. The measurement of the fetus was appropriate for gestational age, with a biophysical profile done, which scored 10 out of 10, indicating a normal fetal well-being. The patient then was admitted to the labor ward and delivery unit for observation. She had an external tachydynamic that showed uterine irritability. Then she was served with magnesium sulfate, betamethasone, and penicillin. All these were administered, but the contraction persisted. After she received additional treatment with oral nifedipine, the contraction stopped. No additional vaginal bleeding occurred, and the hemoglobin level and hematocrit remained stable. Postprandial hyperglycemia was noted, and a regimen of subcutaneous insulin was initiated. The patient was discharged home on the fifth hospital day, and she was scheduled for elective cesarean section. She was scheduled for elective cesarean section at 36 weeks, 4 days. The index pregnancy was desired and spontaneous. Pregnancy was suspected and confirmed via ultrasound at 6 weeks and 4 days. The pregnancy was booked at a community health center. The booking parameters were essentially normal. The blood group was O positive. Genotype was AA. Venereal disease research lab was not reactive. Retroviral screening then was not reactive. Our pack cell volume at booking was 36%. At 16 weeks, 5 days of gestation, the result of our oral glucose tolerance test was abnormal, and the diagnosis of gestational diabetes mellitus was made. Dietary modification, exercise, and finger stick glucose monitoring were prescribed for her. Past athletic history shows that her first pregnancy was 5 years earlier. She had an emergency cesarean section on account of big presentation in labor. Baby was delivered at term without complication. The second and third pregnancies had been electively terminated at 6 and 8 weeks, respectively. Gynecological history in this patient were basically not contributory. Her past medical history revealed that she has no known any chronic medical disease, meaning that she's not a known hypertensive, not diabetic, no sickle cell or epileptic disease. Her family history also were not contributory. Social history showed that she neither smoked nor ingested alcohol. She was married to a 45-year-old trader in a monogamous setting. Systemic review were essentially normal. In summary, she was a 35-year-old, booked gravid at 5 1 plus 2, one alive woman with one previous cesarean scar, who presented with 30-minute history of bleeding per vaginal, having had 2 previous episodes. On general examination, she was a young lady. She was conscious and alert. She was not pale, anemic, afebrile. She was well hydrated. She was obese with a bilateral pedal edema. Her chest finding shows pulse rate, respiratory rate of 20 cycles per minute. Chest was clinically clear. Cardiovascular examination revealed a pulse rate of 98 beats per minute. Blood pressure was 110/70 millimeter of mercury. Abdominal finding revealed a gravidly enlarged abdomen that moved with respiration, visible phanestic scar that healed with primary intention, further height of 36 centimeter, longitudinal line, cephalic presentation, right anterior. The head was 5 feet palpable. Fetal heart rate was 145 beats per minute. Perineal examination shows the vulva were smeared with blood, no active bleeding. Speculum was inserted for this patient for separate examination, and it revealed a closed cervix and approximately 5 mils of dark brown blood in the vaginal, posterior vault was seen with no ongoing bleeding through the cervical os. An assessment of a one previous cesarean scar with placenta previa was made. The plan, she was cancelled on the diagnosis and the line of management. She had 2 white ball cannula that were secured to have IV access. Samples were taken for various investigations, which we are going to see the result in comparison with the final investigation that was done. Urinary catheter was passed. She was booked for emergency cesarean section. She had an anesthetic review for combined spinal epidural anesthesia. Prior to knife and skin, she had cefazolin was administered intravenously before the incision of the skin. A low transverse atrial incision was made through the anterior placenta. Membrane were ruptured bluntly, yielding a clear amniotic fluid. The infant was delivered 37 minutes after injection of the spinal anesthetic agent. Which was administered during the combined spinal epidural procedure with ABGA score of 8 and 10 in 1 and 5 minutes respectively. The placenta was removed with gentle traction. But unfortunately, 3 minutes later after delivery of the infant, white clot and debris were being cleared out of the uterine cavity. The extraoral uterus became blanched with minimal bleeding. Concurrently, this patient was noted to be unresponsive with sporadic respiration. The carotid and aortic pulse were present. Manual ventilation was begun immediately by the anesthetics. 2 minutes later, the patient became pulseless with normal sinus reading seen on the patient monitor or anesthetic machine. Cardiopulmonary resuscitation was instituted, the trachea was intubated, and mechanical ventilation was initiated. 38 minutes after delivery of the infant, generalized bleeding and oozing began with blood and debris emanating from the surgical incision and spreading throughout the operation field. Hemostasis was secured, the abdomen was closed layer to layer. This is the case presentation. So what are our possible differential diagnosis? Possible differential diagnosis in this patient include all conditions that can lead to immediately cardiopulmonary arrest or massive bleeding, which include acute hemorrhage, uterine rupture, eclampsia, peripartum cardiomyopathy. It can be from anesthetic specific diagnosis, which include eye regional block, Other diagnoses can be pulmonary embolism, air embolism, anaphylaxis, cardiac ischemia, arrhythmias, and so we look for what are those things that are for our diagnosis and what are those differentials that we think uh, that this patient may have. Uh, for the differential diagnosis, the close differential diagnosis for this patient, talking about pulmonary embolism, this woman can have the pulmonary embolism could be a differential. However, prior to this to happen, this woman most likely, if from the history, this woman has the risk factor for pulmonary embolism. However, pulmonary embolism usually can occur in the peripartum period, which this woman is within the vein. However, a prior history of a deep venous thrombosis will usually present itself for a patient like this, of which we are going to use it as which is going to be denied us for the clot to occur before throwing an embolus. Also, it can also be an air embolism. For air embolism to occur, we never have any history that suggests air embolism in this patient. However, the chest finding that we normally see is hair muffle that occur in the pericardium of such patients, which no any findings was stated to have occurred for this patient. Sepsis can be a differential. Overwhelming sepsis can be a differential. However, there will be history of usually prolonged amniotic membrane rupture in form of chorioamnitis setting in. There will be fever, there will be lower abdominal pain in this patient prior to for us to make such diagnosis to be due to sepsis. It can be anesthetic complication. This woman had a spinal block. It can be eye regional block. However, in eye regional block, uh, disseminated intravascular coagulopathy usually will not result in such patients. So this is knocking out the chance of having probably a local anesthetic toxicity or even eye regional block. Uterine rupture, yes, it can be a differential. However, this woman, because she has a risk factor including previous uterine scar, lower segment uterine scar. However, this woman has not been in labor, and there's no any history of use of any osteotics, which can be and from other findings, she had a very the primary incision, the panestic scar healed by primary intention, meaning that she had good scar integrity, and there was no any history of labor in this patient. Hence, uterine rupture may likely not to be, it can be a differential. Eclampsia can be a perfect differential diagnosis in this patient. However, there's usually a prehistory of preeclampsia, which is elevated blood pressure with significant proteinuria, which were not found in this patient, and from the investigation, result of this investigation never revealed such. And the blood pressure that we have hypertension, unlike in eclampsia, which usually 80% are usually of elevated blood blood pressure, which will be the normal finding that is found in patients like that. Transfusion and reaction. This can also occur because it's a form of anaphylactic reaction, which can present itself like this. However, there's no any prior history of blood transfusion in this patient. Her hemogram were stable even prior to the surgery, so she had no any blood transfusion in her that would have suggested that. So, looking at all these differential, the most likely diagnosis for this patient is likely amniotic fluid embolism. So, what are the criteria that made us to say this woman is likely the diagnosis is amniotic fluid embolism? One, there is acute hypertension and or cardiac arrest that occur in this patient. There is also an acute hypoxia, which is diagnosed by dyspnea, cyanosis, and or respiratory arrest, which all these are present in this case. Coagulopathy or severe clinical hemorrhage in the absence of other explanation, which this triad are all present in this patient, and all these can either occur during labor or during cesarean delivery or dilatation and evacuation, or and all this must occur within 30 minutes postpartum with no other explanation for the findings. So looking at this index case, we can see all these three diagnosis, all these three criteria are meant in this case presentation. And by the time we look at our investigation that was done for this patient, they are also keeping with the likely findings that are found in patients that have amniotic fluid embolism. Looking at our hemogram, from this result, we have the hemogram that shows our hemogram 19 days prior to admission and 45 minutes after the incident. You can see that our blood pressure, white blood hematocrit were within normal, were within uh, were within normal. Initially, it was 35.4%, which is normal for pregnancy. However, after the event, we're having 28.9. She has lost a significant amount of blood, which usually occur with disseminated intravascular coagulopathy, which is one of the features because of the consumptive coagulopathy that occur in patients with amniotic fluid embolism. Looking at the white blood cell count, the white blood cell count was normal 19 days prior to admission. However, looking at the events that occur at the white blood cell at 45 minutes, we can see that it is slightly elevated, which is one of the active phase protein that rise up when there is a stressful condition like this in patients that have a disseminated intravascular coagulopathy. So with these findings is also keeping with what is expected in patients that have such diagnosis. Looking at the platelet count, the platelet count is also low. Initially, it was 203,000, which was within normal. However, now there is thrombocytopenia, which is 64,000 below normal, which is also keeping with what we have in disseminated coagulopathy part and component of active amniotic fluid embolism. Other important finding is the prothrombin time. The prothrombin time, you can see it has increased. It has increased to 18 minutes, which was initially normal, but now it's now 18 minutes in this patient. Hence, she's likely to bleed as was presented in the case. The fibrinogen level is going to be low, which is keeping with the diagnosis is 81, and fibrin degrading products may be usually they are elevated. Uh, the arterial blood gases, initially there's going to be a rise in the partial pressure for carbon dioxide. Initially there will be a rise, and this is keeping with what we have uh, in this uh, in this patient. Whereas that of the oxygen, initially there will also be a rise, and suddenly we now start having hypoxemia, deepening hypoxemia, and we have cyanosis. And this cyanosis is what being the clinical finding that you see that occur right on the blood, in the brain. You can have convulsion in such patients. Now, what are the other investigations that should have been done in in this patient? In management of patients with amniotic fluid embolism, uh, the other diagnosis that could have been of help that have not been done in this patient, we have some specific and non-specific. The diagnosis of active fluid embolism initially are usually done post-mortem, and later with advancement in investigation, samples of the pulmonary blood can be taken to check for the presence of squamous cell coated with neutrophils and presence of fetal debris. All these are the diagnosis, these are the tests that were done. However, in the recent tests like zinc and copropophyrin, which are usually elevated in patients because of the amniotic fluid, because they are important component of the amniotic fluid. Likewise, there is sialate CN antigen, which are antibodies that are which are compounds that are found in mucin. They are usually mucin of amniotic fluid. They are usually elevated, and they are raised in patients that have amniotic fluid embolism sample are taken. Serum tryptase level are usually raised, but may become normal, so it's not diagnostic. Other ancillary things that could have been done for this patient, if by the time you do your chest X-ray, you are going to see right ventricular hypertrophy, right ventricular hypertrophy, and your ECG is going to show a sinus reading, but there's a right heart strain. Then the ventilation perfusion mismatch are usually present because of the infiltration of the pulmonary vessels. Hence, reduced arterial blood gas can be found. And like we said, coagulation problem, which will bring low platelets, increased prothrombin time, and ABCT and low fibrinogen. So, from all indication from this patient, we can say that the diagnosis for this patient is amniotic fluid embolism. To educate ourselves more, amniotic fluid embolism is a catastrophic obstetric emergency that can present as sudden, profound, and unexpected maternal collapse. It is associated with hypertension, hypoxemia, and disseminated intravascular coagulopathy. It usually occurs when amniotic fluid, fetal cells, air, and other debris enter into maternal circulation. Some also call it anaphylactoid reaction of pregnancy. Most cases of amniotic fluid embolism actually occur during labor after you do your artificial rupture of membrane, but 70% of them occur during labor. 19% occur during cesarean section, and 11% usually occur following vaginal delivery. The etiology has remained unclear. However, some theories that have been postulated say that AFA is an immune-mediated response to the presence of those material amniotic fluid in the maternal circulation. Also, the true incidence of amniotic fluid embolism is actually unknown, but it has been shown to be within the range of 1 in 8,000 to 1 in 80,000 of pregnancy. It accounts for 4.7% of direct maternal death in United Kingdom, 13% in France, and 30% in Singapore, and up to 10% in USA and Australia. Values from Africa are difficult to find because of we hardly do autopsy or post-mortem autopsy for most of our patients. Majority of patients with amyloid prevalence, they die within hours of onset of symptoms. However, about 5% of those that survive, they have some form of permanent neurological impairment. Like we said, it has affectation in the brain, so they can have multiple convulsions, and this affects their neurological status. If the fetus is alive at the time of the event, nearly 70% will survive. Will survive delivery, but 50% of the survived unit will actually incur some form of neurological damage, because during this condition, blood supply to the uterus has been reduced. Hence, the baby is going to suffer some form of hypoxemia, and another day will have some form of cerebral palsy. What are the risk factors? Risk factors for amyloid embolism include advanced maternal age, multiparity, meconium stain lichen, intrauterine fetal death, diabetes mellitus, polyhydramnios, strong frequent or tetany uterine contraction from induction of labor and augmentation of labor, maternal history of allergy or atopy, chorioamnitis, and uterine ruptures. Also, placenta uh, abnormality in form of placenta accreta or abruptio placenta are also indicated. Cesarean section is also a risk factor, which in this patient, she is of advanced maternal age, she is multiparous, she is diabetes, she has gestational diabetes, and also she had her placenta accreta. More than 5 of the risk factors, notable risk factors, are present in this patient. Hence, diagnosis of amyloid fluid embolism is most likely likely the diagnosis. So, the basic pathophysiology of amyloid fluid embolism that have been postulated shows that the amyloid fluid enters the maternal circulation usually through the rupture membrane or the rupture uterine or cervical vessels down a pressure gradient from the uterus into into the vein. Although the site of placental implantation is one portal of entry, small tear in the lower uterine segment and endocervix are thought to be the most common site of entry. The pathophysiology actually is unclear. In the past, it was thought to be due to fetal tissue amyloid forcibly entering the maternal circulation, causing some form of transient pulmonary vasospasm, cardiac failure, hypoxemia, and later death. However, in 95, Clark and al. Suggested that this syndrome actually arose from an immune rather than embolic process that we have mentioned earlier. And according to Clark, he says the amyloid embolism that is caused by the fetal antigen in the amyloid fluid, they stimulate a cascade of endogenous immune mediators, which produce a similar reaction of anaphylaxis, similar to anaphylaxis. The biochemical mediators found in solution are thought to trigger the main feature of anaphylactic reaction with multi-systemic involvement: the cerebrum, the respiratory system, the cardiovascular system, and the hematological system. So Clark actually divided it that it's a biphasic response. We have phase 1 and phase 2. The phase 1, the amniotic fluid and the fetal cell, they enter the maternal circulation. This results in the release of biochemical mediators that will cause the pulmonary artery to become vasospasm. This will bring about pulmonary hypertension. With the pulmonary hypertension, this will result in elevated right ventricular pressure, and right ventricular dysfunction will occur, which will lead to hypoxemia and hypotension with associated myocardial and capillary damage. This phase 1 usually lasts for 30 minutes. And after 30 minutes, you will now start having your GIC, which is keeping with what we have in this patient. The phase 2, this occur in patients who survive the initial insult. Left ventricular failure and pulmonary edema occur. The biochemical mediator will now trigger the disseminating vascular coagulopathy, leading to massive hemorrhage and uterine atony. In conclusion, Amniotic fluid embolism is a condition that is unique to pregnancy and is the leading cause of maternal death in developed countries. With modern resuscitation technique and intensive care, treatment survival is much improved, such that amniotic fluid is no longer a post-mortem diagnosis. We can actually diagnose from the pulmonary blood sample. Aggressive and early resuscitation of parturients with amniotic fluid embolism is frequently associated with good long-term maternal and neonatal outcome. Atypical presentation do occur, so the diagnosis of amniotic fluid embolism should always be considered in acutely unwell parturients, and treatment should be instituted as soon as possible so that we can have a good outcome. Thank you very much. My acknowledgement goes to the chief admin himself, the faculty of obstetric and gynecological members of Dr. Assembly. These are my references. Thank you for your audience. Thank you.
Thank you very much, Dr. Njigla. We actually enjoyed every bit of the presentation. Now, we are going to be taking comments. Dr. Nandi, did I get it? The pronunciation? Please, you can unmute.
Yes, sir. You got my name correctly. It's Dr. Nadi. Thank you very much, sir. Thank you so much, the presenter, for such a wonderful presentation. I do not really agree with the diagnosis of completely with the diagnosis of amniotic embolism for this patient. I was taking more of a concealed abruptio placenta. Given that this patient's HB dropped 28, there was also a history of coagulability, reduced fibrinogen from the investigation we saw, and we were not told about if there's any retroplacental placenta clot following the delivery of this patient. That would have also helped probably to support or refute the diagnosis of abruptio placenta, and also the EBL was not made known to us. Secondly, I also thought about a high spinal anesthesia for this patient, given the sudden deterioration in the cardiorespiratory system. Those are just the contribution I wanted to make, sir. Thank you.
Thank you so much, Dr. Nandi. Please, I would like to know your center, sir.
Okay, sir. Yeah, I'm a registrar in Lasuth, sir.
Okay, sir. Nice having you around. Nice having you around. Thank you very much. So I've noted your contribution. Dr. Mutiat was saying on the chat that may I ask why HELP syndrome, that's the HELLP syndrome, was not considered as a differential in this patient. I think Dr. Sheu Jamiu will be responding to that shortly.
Okay, thank you for the contribution. Like we said, that most of our differentials for this patient, like I said any condition that presents as acute cardiopulmonary collapse or massive hemorrhage in the pericardium must be their differentials, and they must systematically evaluated in this patient. But looking at the presentation, why abruptio placenta is not diagnosis of it's not diagnosis of choice for this patient is she had had two previous episodes of bleeding papillomatum which were unprovoked, and she had she's a previous she had previous cesarean scar, and she had ultrasound that was done. The first was done when she was around 16 weeks. Second one was done when she was 33 weeks, and all were features showing that the placenta were close to the cervix. We are even covering the cervical os, which is still diagnosis of what? Placenta previa, and her bleeding was painless, and she has no other risk factor to show that abruptio, even though our age, our parity are keeping with abruptio. However, the location of the placenta and nothing was telling us about verteplacental clot. Hypertension, which is the commonest risk factor for abruptio, is not there in this patient. So that makes us to downplay the diagnosis, because we know with abruptio they can have consumptive coagulopathy, dissemination of the vascular can occur. However, the concept of having cardiopulmonary arrest, as it was painted in the scenario during the cesarean, is hardly to happen with abruptio placenta. It's hardly to occur with abruptio placenta. Likewise, for the speaker that asked about HELP syndrome, HELP syndrome usually in obstetric practice is a complication of preeclampsia eclampsia, whereby you are going to have hemolysis, elevated liver enzymes, and low platelets. From the history, from all what we have in this patient blood pressure has been normal. There is no proteinuria. She has no any liver pathology. There is nothing like acute fatty liver or pregnancy. So she has no liver pathology that will have made her to have any elevated. You must have those three features for you to make your diagnosis of HELP syndrome. There should be hemolysis. We never had in examination that this woman was etheric, believe within at any time, even though the blood cells were the level was low, but we know she's losing it via bleeding. The platelet level were low. We know that this happened because of the DIC that she has, which the cascade began with what? Because of the presence of the fetal stem cells in the circulation. This also triggered conjunctive coagulopathy. So the kind of HELP syndrome is may not likely be entertained totally in this patient, because there is no any history of elevated blood pressure, no liver pathology whatsoever in this patient prior to this problem. And also, HELP syndrome doesn't come as an emergency like this. It is a progressive condition that will come, but not an untable event as we have in this case.
Thank you so much, Dr. MJ Black, for the clarification. So we go to the verdict. My name once again is Idris Kodri, and this 35-year-old healthy woman who was undergoing a repeat elective cesarean section for placenta previa had sudden cardiovascular collapse moments after delivery of the placenta. While cardiopulmonary resuscitation was initiated, we began to rapidly construct a differential diagnosis to identify the underlying cause and to institute appropriate interventions. While we were trying to construct our differential diagnosis, the following came to our mind: pulmonary embolism, hemorrhage, venous hair embolism, anaphylaxis, high cephalad, spread of neuraxial anesthetic agent, peripartum cardiomyopathy, myocardial infarction, eclampsia, and amniotic fluid embolism. You will notice red and green in some of my write-up. The red are actually the ones that we found in the patients, while the green are the features that ruled out this particular condition in the patient. Now, I will start with pulmonary embolism. In support of this diagnosis was the acute nature of the event and the fact that the patient had severe risk factors for pulmonary embolism, including hypercoagulability, pregnancy, advanced maternal age, and obesity. However, in preparation for surgery, sequential compression devices were placed on the patient's leg to prevent the development of deep vein thrombosis. Furthermore, in the absence of deep vein thrombosis, which was not noted during placement of the compression devices, it would be unusual for a clot to form and migrate so quickly during surgical procedure. In addition, the patient lost consciousness without any reports of dyspnea or chest pain, symptoms that often precede a pulmonary embolism. Nevertheless, pulmonary embolism is one of the most common causes of cardiovascular collapse in pregnant women and cannot be ruled out in this patient without the performance of diagnostic imaging and laboratory tests like Doppler ultrasound of the lower limb and so on. Hemorrhage. The patient had multiple risk factors for hemorrhage, and this was the adverse outcome for which we were most prepared. Given that she had had a previous cesarean section and she had a complete anterior placenta previa in this pregnancy, we had concern about potential placenta accreta. We observed no signs of placenta accreta on antenatal ultrasonography, but we were prepared to administer blood products if clinically significant bleeding developed. The placenta was delivered with ease, the uterine tone was excellent, and bleeding at surgical sites was well controlled. We handed the newborn to our colleagues in pediatrics, and just after we sterilized the uterus, the patient became unresponsive. Hemorrhage as a cause of acute cardiovascular collapse was quickly dismissed because there was minimal bleeding at the surgical site and the uterus appeared entirely blanched and malperfused. Venous hair embolism has been reported to occur at time of cesarean section. The diagnosis should be considered anytime the operative site is positioned above the patient's heart, which occurred in this patient when the uterus was sterilized. However, as is the case with a pulmonary embolism, these events are often preceded by wheezing, dyspnea, chest pain, and gasping. Anaphylaxis was also considered, given that many medications were administered to these patients before and during the procedure. However, patient did not have any known drug allergy, and the timing for an anaphylactic event did not fit well in this case, since cardiovascular collapse occurred more than 30 minutes after these treatment exposures. In addition, no rash, no hypotension, no dyspnea or wheezing preceded these events. High cephallar spread of neuroaxial anesthetic agent, which is also called a high regional block. It can cause sudden loss of consciousness and cardiac arrest. But in this case, the event occurred more than 30 minutes after injection of the spinal anesthetic agent, which was administered during a combined spinal epidural procedure. There were no technical difficulties with injection of spinal anesthetic agent, which resulted in analgesia bilaterally at the level of T4 dermatome. No medication was injected through the epidural catheter. In addition, there was no evidence of respiratory distress, difficulty in swallowing or talking. There was no bradycardia, no weakness in the arms leading up to the event. Another differential is peripartum cardiomyopathy and myocardial infarction. Yes, this patient had risk factors for peripartum cardiomyopathy, including being in late stage of pregnancy, being of advanced maternal age, and being of African descent. However, before undergoing the surgery, the patient was in a usual state of health and did not have any symptoms that were consistent with heart failure, such as worsening dyspnea or pedal edema. Myocardial infarction is rare in women of reproductive age. These patients had several risk factors, including pregnancy, advanced maternal age, and obesity. However, this patient presentation would not be typical for myocardial infarction, given that she had no dyspnea, no history of chest pain, no nausea leading up to this event. Furthermore, when the patient became pulseless, she remained in sinus rhythm with no evidence of clinically significant ischemia seen on the patient's monitor on the anesthesia machine. Another one is eclampsia. It should be considered because this woman is pregnant and she has an acute change in her mental status. However, this patient was normotensive and did not report headaches, visual changes, or pain in the right upper quadrant that might suggest HELP syndrome. Also, she did not show any signs of seizure activity. Last but not the least is amniotic fluid embolism. Despite the advances of modern medicine, amniotic fluid embolism remains one of the most feared diagnoses of obstetrical providers. just like Dr. M.J. Black has called it, it's a catastrophic obstetric emergency. These events are rare, with an estimated prevalence of 1 in 16,000 to 50,000 deliveries. The outcomes are catastrophic, as I've said, with mortality rates as high as 20 to 60% in the United States. I don't know that what will happen in Africa if the United States is having 20 to 60%. And among those who survive, 61% are left with clinically significant neurologic consequences. Unlike placenta accretia, amniotic fluid embolism remains an unpredictable event with no demographic or clinical risk factor that have been sufficiently studied to justify alteration in standard obstetrical care. Amniotic fluid embolism is often described in the context of classic biphasic triad of events that includes sudden cardiovascular collapse occurring around the time of labor and delivery, followed by development of coagulopathy and hemorrhage. I won't bore us with details. This is just a summary of the pathophysiology that Dr. Sheu Jamiu has just taken us through. During the assessment of this patient, she also had an echocardiography done to show the activity of the patient's heart. I'm going to play a video for you, and you are going to see what happened on echocardiography. Now, that is the patient's heart. This is the right ventricle. This is the left ventricle. This is actually a transesophageal echocardiography. You can see the right ventricle is looking dilated. And when I play the video, you can see that the activity, just look at the interventricular septum. You can see the movement. The movement is not so good enough. It's just sluggish, and the right ventricle is looking dilated. Now, that is what we see because the right ventricle is strained just because of the problem that is happening in the pulmonary circulation. The pulmonary vasospasm, pulmonary hypertension will be putting strain on the right side of the heart. And that's why we have the right-sided ventricular enlargement. Now, let's continue. Now, in the second video, you are going to see this is when we interrogated the blood flow. You can see that. Let me stop. I want to show you something. This is the color flow of the heart, tricuspid regurgitation in this patient. It's one of the features that we see in patients that are having right ventricular failure. So let's continue. Now, it's obvious that this patient is having problem with the right ventricular aspect. Now, this is the transgastric view of this is the right side of the heart. You can see it's dilated and is reducing the size of the. Now, after inotropic agent has been given to the patient, you can appreciate the size of the right ventricle now. You can see that the right ventricle has reduced. The size has reduced now. That means the right ventricle has picked up again in this patient after we have given inotropic agents. So I will let you have a feel of how the heart is pumping. That's video 5. This is the transgastric approach. You can see now that the interventricular septum is actually moving the way it should. So again, this is the right ventricle. This is the left ventricle, left atrium, right atrium. And you can see this is how the normal heart should be. So the patient's, the cardiac symptom improved after inotropic agents has been given to the patient. So let's continue. The first insult was cardiovascular collapse. Most likely results from vasospasm of the pulmonary vasculature with a significant, clinically significant hypoxemia, heart failure on the right side, and cardiac arrest. This patient presented with cardiopulmonary arrest, which is one of the most common presenting signs and symptoms, and it is reported to occur in 87% of women with amniotic fluid embolism. If the patient survived this initial insult, dilatation of the right side of the heart occurs, which leads to compression of the left side, decreased filling pressure and heart failure, followed by elevation of pulmonary artery pressure. Subsequently, the right heart function will improve. In patients who survive the initial cardiac arrest, then they are going to have a severe consumptive coagulopathy. Other common signs that we see are hypotension, fetal distress, and pulmonary edema. These patients had the classic triad of events associated with amniotic fluid embolism, making this the most likely diagnosis in this case. My final verdict, the final answer is amniotic fluid embolism. The management of this case, as I've said, is contained in the documents, which I'm going to share on the assembly, doctor's assembly page. Once again, I would like to thank you all for attending this presentation, and it's a lovely one from the Faculty of Obstetrics and Gynecology. I would like to appreciate our presenter, Dr. Sheu Jamiu, for doing justice to this case. We are going to be having more, and our next presentation that will be coming up in June will be by the Faculty of Psychiatry or Behavioral Science, and they are also going to be giving us something very, very interesting. And please, our YouTube page is still up and running. We have all these presentations, and this one will also be joining the interesting presentation on our YouTube channel. Please just subscribe to our YouTube channel so that you can have you can get notifications by the time we post another interesting video. So on behalf of all the honorable members of Doctors Assembly, I want to say thank you once again for coming, and have a blessed night.